Okay, hello everyone. Welcome to ASPA-FLEX webinar series, and thank you for your sharing your time to this webinar. This program is, next please. This program is presented by ASPA E-Education Committee and supported by WFSA. Okay, let me introduce myself before the webinar. My name is Hee-Soo Kim, a pediatric anesthesiologist in Seoul National University Hospital, and I'm a leader of today's webinar. We have another moderator. Next slide, please. We have another moderator, Dr. Teddy Stratos Fabula, also a pediatric anesthesiologist in KKH in Singapore. He is very active and interested in pain, hospital quality and safe standard, medical informatics, and education. And Dr. Viva Naik is a technical supporter, and I'd like to give a big applause to Teddy and Viva for their support. Today's topic is anesthesia for pediatric ambulatory surgery. We have 4 distinguished speakers, and each speaker will present a specific topic of pediatric ambulatory surgery. Each session will be 20 minutes, and the last session will be Q&A session. Before starting the webinar, I'll give you some organizers' announcement. If you have any question or comments, you can use the Q&A box instead of chat or raise a hand box, and the appropriate speaker will answer the question during the webinar. And we will highlight the question to appropriate speaker in the Q&A session. Any question will be welcomed. Certificate of attendance will be automatically generated and forwarded to those who submitted the post-webinar survey. Post-webinar survey will be forwarded to you until tomorrow. And please ensure that your full name and email is correct when you answer the post-webinar survey. This webinar will be recorded, and you can review this video in ASPA homepage or YouTube. Okay, let's hit the road and go to the first session. The first speaker is Dr. Ekta Ray, and she is the head of Pediatric Anesthesia Unit in Christina Medical College in Vellore. Also, she is an associate editor of Pediatric Anesthesia Journal. Her interests are pediatric anesthesia, especially regional block airway ventilation and ambulatory anesthesia, focus, and other researchers. I'd like to explain how to polling the question. When a polling is launched, you will be prompted to answer the polling question. You will have 30 seconds to respond and submit your answer. We will share the results soon after we end the poll. After the results is shared, you may close the poll so that you can see the slide shared by our speaker. Okay, next, please. Okay, Dr. Lai, please.
Good afternoon, everyone. I bring you all greetings from Christian Medical College, Vellore. It's a tertiary care center in southern part of India. At the outset, I would like to thank ASPA-FLEX webinar series for having me here and allowing me to talk on preoperative assessment of children for ambulatory anesthesia or surgeries. Ambulatory surgery is need of the hour as it goes in accordance with the fast pace of life, the nuclear family structure, early need to return back to the daily activities. And also with this increasing population, there's always a relative shortage of beds. So it serves all purpose. Now coming to children are perfect candidates for ambulatory anesthesia because they hold good health, their surgeries are short, and they like to recover in their own surroundings. And when I talk about pre-op assessment for these children coming for surgeries, so pre-op assessment is like the foundation of a strong building. You have a meticulous pre-op assessment, you will get a successful surgery. I have no conflict of interest. Looking back into the history, the first anesthesia was actually office-based anesthesia in 1840s. Now it's Dr. Ralph Waters who was the first one to establish the first outpatient center in Iowa City. From 1918 to 1970, there was this trend of ups and downs where the complications has halted the the success of ambulatory anesthesia, but it's only 1990 when there was this explosion of ambulatory anesthesia and ambulatory surgeries. And from there was no looking back. As per CDC 2009 survey, the US data states that 70% of the anesthetics are ambulatory in the US, and of that 50% are actually hospital-based rather than freelancing. Coming to developing countries, the number is little less, 15 to 30%, and there's a lot more scope to grow. Coming to my talk for today, we will talk in terms of timing of pre-op anesthesia checkup. We'll talk about how to select a patient procedure, facility, etc. And then we talk about few comorbidities and details of that, when and how to accept. Coming to PAC, based on demographic, based on invasiveness of procedure, clinical condition of patient and healthcare system, the PAC can be done a day before or on the day of surgery. In my setup, usually we see these children 3 to 4 days before, and then again on the day of surgery. Today, we are very lucky to have Dr. Rafat with us. He's got immense experience on ambulatory anesthesia for children. So, so when we talk about selection criteria for these children, it depends on one, what procedure we are taking. Then it depends on who is the child, what comorbidities the child has got, who is the provider, and what facilities you have around. Coming to procedures, these are various number of surgeries which can be done as ambulatory surgery, and the common factors among them are they're all short duration surgeries. They usually should be less than 120 minutes or 2 hours. They don't have high risk for post-op bleeding or post-op pain. So these are the category of surgeries we must accept in ambulatory, but it's not only surgery, but the indication also is very, very important. Like in tonsillectomy surgery, the indication can be chronic tonsillitis or it can be obstructive sleep apnea. And as we all know that obstructive sleep apnea has got high risk for respiratory adverse events. Now, my first polling question is, Dr. Weber, can we have polling question? So the first polling question is, what is the youngest age recommended for hernia surgery in an ambulatory setup for preterm babies? So your polling is open now. All right, so we have polling results with us, and most 91% of our people here, 64%, I'm sorry, 64% of the people here say that more than 60 weeks post-conceptual age is the age for the daycare setup. So let's see what we have to say. Coming to patient factors, there are basically two important things. One is age, the other is comorbidity. Coming to age first, for minimally invasive surgeries based on apnea surgery, based on apnea studies, the grade A recommendation is preterm baby who have crossed 60 weeks of post-conceptional age, or the full-term babies who have crossed 45 weeks of post-conceptional age are the good candidates for ambulatory surgery. This age is not standard across all surgeries. As you can see, for adenotonsillectomy, as per ASO guidelines, more than 3-year-old child is a candidate. If the child is less than 3 years old, they only do adenoidectomies in the ambulatory setup. Coming to comorbidities, earlier we used to accept ASA 1 and 2, but now we have extended to ASA 3 for ambulatory surgeries. And today I'm going to talk about upper respiratory tract infection, anemia, asthma, congenital heart disease, and malignant hyperthermia for these children. Special children and obesity will be taken up in different talks by other speakers. So the topics under which we are going to discuss is when can I accept, how can I identify severity, and how can I optimize. Coming to upper respiratory tract infection, we all struggling currently. The whole world is struggling with URTI and this coronavirus, but I'm not going to talk about it in this talk. URTI is nothing but a symptom complex. It can be as high as 10 episodes per child per year. Each episode is around 2 weeks, and the airway remains active or reactive for next 2 weeks. So you can imagine for every episode, 1 month is required for complete healing. So there's a big question whether to accept them for surgery or whether to postpone. If you conservatively keep postponing, probably they may not be able to undergo any surgery because almost out of 12 months, 10 months are gone with the upper respiratory tract event. So we have to be judicious. So the answer lies on the child's health, facility, and expertise available. For child, symptoms like mucopurulent secretions, fever, dull-looking child as per parents, they are high risk for respiratory adverse event. If the child has got asthma and there is even mild upper respiratory tract infection, the chances of respiratory adverse event perioperatively is very high. If you're planning for oral airway surgeries or shared airway surgeries, where you're planning to put endotracheal tube, the chances of respiratory event are still higher. So they may not be the best candidates for ambulatory surgery. Comfortably, you can choose mild cough, you can choose clear running nose for ambulatory setups. Remember to involve family in all cases because they should be aware that what kind of risk lies. And you must know what treatment they are on, especially the herbal medications, because herbal medications have got interaction with anesthetic drugs and other drugs. So when you talk to parents, you must give them a number. You must tell them that because of these reasons, the respiratory events are, or chances of respiratory adverse events are higher. For this, you need a validator score, and COLD score is one such score where the score, higher the score, more the chances of respiratory adverse events. So in summary, mild symptoms, no history of asthma, no passive smoking, no need for endotracheal intubation, expertise available, you can accept these patients. And remember to always optimize, and simple way to optimize is to use saline drops, Otrivin nasal drops night before, beta-2 agonist nebulizations. Coming to anemia, which I see regularly in our setup, again, there's no need to do hemoglobin, a routine hemoglobin, but based on history examination, if there's lethargy, patient is lethargy, effort tolerance is reduced, pallor present, you can go for hemoglobin. Remember, for more than 2 years, hemoglobin 8 gram per deciliter is fairly a good number to have, and the complication associated with this is found to be less. When you're dealing with a smaller child, remember anemia is associated with apneas. So be mindful of that. Coming to asthma, very frequently seen respiratory disease. Look for duration, treatment history, increase in steroid use, recent exacerbation, hospitalization, allergies, passive smoking. All these factors are high risk for or increased risk for respiratory events. So be mindful of them. So when can you take them? If there is a recent flare of disease requiring steroids for controlling them, unabated wheezing, fever and saturation of less than 95, then they are not the candidates for ambulatory surgery. Now coming to congenital heart disease, a big no to single ventricular pathologies in ambulatory setup. So try and do the risk stratification, and the low risk patients can be taken up in ambulatory setups, and these are generally repaired ASD, VSD, and mild valve disease with minimal gradient. So in summary, If the child is developing well, if there is no exercise restriction, if they are undergoing regular follow-ups, then the child with corrected cardiac disease can be taken up for surgery. But you have other categories where you can make individualized decisions. Coming to malignant hyperthermia, if there's any history present which says there is sudden death of patient under anesthesia, they are big no to ambulatory surgeries. Remember, even if you're not taking patients with this history, your setup should be prepared for MH management. Having said that, having said this, my setup, I have dentuline available around 130 kilometers from my hospital. For small children, cigarette smoking is equivalent to passive smoking. So you make sure you advise parents to stop smoking at least 8 weeks before. If you're dealing with teenagers and they're smoking, then you must tell them to stop smoking around the same time, because the changes seen after 8 weeks are beneficial for the overall outcome of the patient. Coming to investigations, there's nothing called a routine investigation for ambulatory surgery. They are not only not useful, but they can also be harmful because they can cause financial burden. They can cause unnecessary anxiety among this set of people. Coming to common tests like hemoglobin, CBC, urine analysis, they are not routinely, chest x-rays, they are not routinely done. Coming to coagulation testing, especially for tonsillectomy, few setups do them as a routine, but there is no beneficial effect found just by the numbers, because these baseline values does not predict the post-tonsillectomy bleed in any ways. So only recommendation for coagulation testing is if there is history examination suggestive of excessive bleeding. When you see these children, anticipate the complications, especially the respiratory and cardiac complications, and documented. Also also think about post-op nausea, vomiting, because they are high-risk patients, and again documented, and suggest the modification in anesthesia plan. Now, after we covered procedures and patients, coming to performers or intervention or the anesthetist, perioperative respiratory complications are found to be less when expert pediatric anesthesiologist handles the child. Coming to facility, it can be hospital integrated, it can be hospital based, it can be freestanding, it can be office based. In any case, you must know your facility, and based on that, you must choose your patient. Coming to polling question number 2. Now, facility does not only mean the. So the polling question number 2 is, what is the type of your ambulatory surgery setup? So we have the results with us. 60% of our delegates says that they have hospital-based facilities, followed which hospital integrated, and 34% of the delegates, 5% do have freestanding ambulatory setup. And it's just that we have to be aware that when we have freestanding ambulatory setup, we have to be extremely careful in choosing the patients. Over to you. Good afternoon, everyone.
Okay, thank you for your interesting presentation.
Now, facility does not only mean the hospital facility, but very important part is the house and the facilities available at the home. So things like you need to have a dedicated adult to look after the child. You must have communication and transportation facilities. The hygiene at home should be fairly good. and hospital within 1 hour of the home should be there. Now, pre-op anesthesia checkup also has a very important service to do, which is to allay anxiety for the parents and the child. Remember, if parents are anxious, children are anxious, and if children are anxious, they have got a higher chances of emergence delirium. So at this point, clarify their doubts and give them very clear instructions. So the first and foremost question which keeps popping up nowadays is, will my child have a neurodevelopmental delay? So the answer for this comes from 3 important studies. One is PANDA study, which says there's no difference between exposed and unexposed children with anesthesia, and their IQ performance fairly is okay. GAS study also says if you're using sevoflurane for less than 1 hour in smaller children, at 2 years, their outcome, neurodevelopment outcome, is same as the ones who have got regional instead of general anesthesia. MAS study again has the similar findings. So with these 3 main studies, you can say no significant neurocognitive deficit for short anesthetic exposures early in the life. Coming to polling question number 3. So the polling question number 3 is, what is your practice for anesthesia in a child who is recently vaccinated with inactivated vaccine like IPV or Hib? Okay, we have interesting results here. 38% feels that they will postpone the surgery for 2 weeks, whereas 31% feels that they will go and anesthetize as per plan. We have 18% of population which says that they'll postpone surgery for 48 hours, and 13% feels that they need to know. So let's see what happens. Now, second important doubt which keeps coming up is regarding the vaccination. The parents keep asking, my child is due for vaccination. Shall I hold on with vaccination or shall I carry on with the vaccination? So remember, anesthesia does immunomodulation, but it's very minimal and does not change the outcome or the effect of vaccination. So it is all right to vaccinate. Only problem is, especially in inactivated vaccines, the symptoms arise within 48 hours. And so they can be diagnostic concern when these symptoms with fever or rashes are there after vaccination. So it's better to delay inactivated vaccine for 48 hours. Regarding special children, if it's a daunting task to immunize them generally, under anesthesia, they can be immunized. Fasting, this is the time you must give them a clear fasting instruction, especially the times, not the duration of fasting for them. And also you must explain what can happen if you don't fast appropriately. Discuss analgesia in detail. All the instructions should be given to them, must be written, and there must be a contact number which they can contact in case of doubt. You must have your plan B and C ready. Plan B generally is like your child can stay for a longer time in recovery, or plan C can be admission in the hospital. If you don't have plan C, choose your patients very, very carefully. So to take home message after my talk, basically you must understand your patients, your facilities, procedures, surgeons, and your limitations. And based on that, make a call on accepting for ambulatory surgery. One size does not fit all. So brainstorm and plan for yourself. Meticulous pre-op assessment is the key for success of ambulatory anesthesia, and there is no alternative to updated knowledge. With this, thank you. Good afternoon, everyone. Good afternoon, everyone.
Okay, thank you, Dr. Ekta Ray. Thank you for your excellent lecture. And we move on to the second session. Next slide, please. Okay. Next speaker is Dr. Rafa Hanalal, and he was past president Society of Ambulatory Anesthesia and Professor Emeritus of Anesthesiology and Critical Care Medicine and Pediatrics, the George Washington University School of Medicine and Health Science. And his interests are pediatric anesthesia, ambulatory anesthesia, and musical theater. Okay, Dr. Hanalal, please.
Thank you, Dr. Hee-Soo. I am honored to participate in this ASPA-FLEX seminar on anesthesia for pediatric ambulatory surgery. In working with children, our goals are to, of course, maintain safety, provide smooth onset, and control of depth. And for ambulatory patients, ensure rapid emergence and quick discharge readiness. While controlling pain and postoperative vomiting are important, this will be covered by the next speaker. Since there are many locations where ambulatory surgery can be performed, in this lecture, I'll stress that the flexibility to schedule sicker patients or more complex procedures will be more in a hospital-based facility where a slightly longer recovery can be arranged than in a freestanding ASC or an office setting where this option is limited. We must remember that there are many regulatory policies available now that will help guide our practice and contribute to the safety of children in ambulatory surgery. We'll do so while briefly discussing 4 clinical scenarios: working with infants and young children, the new fasting guidelines and need for IV access, T&A surgery for obstructive sleep apnea patients, and accepting obese children at an ASC. Let's start by looking at the American College of Surgeons, ACS proposal for ASC and how that affects our practice. What they require, what they suggest is to have, let me just do this here. Okay. Is to have only healthy children aged 6 months or over undergoing low-risk surgery be performed at an ASC, a freestanding ASC. The ASC should have a transfer agreement with a nearby hospital in case that becomes necessary. And they emphasize that people who work at the ASC, both anesthesiologists and surgeons, should have specific pediatric expertise, because the chances of perioperative complications are about 5 times higher when practitioners have low expertise, like in this case here showed on red, under 100 cases per year, which is basically 2 cases per week, will have 5 times as many complications as those who are able to perform more than 200 cases per year. Now, as we have heard already, the risk of postoperative apnea is real in preterm infants. There have been many studies, and there is conclusive evidence that infants who are born prematurely and are still under 60 weeks post-conceptual age have high chance of post-anesthesia apnea. For full-term infants, though, the evidence is not really very strong. There are some case reports showing that there is possibility of apnea in the very young babies, but there are no research data to support this assumption. However, with that, the American Academy of Pediatrics has a policy statement that requires and recommends postoperative monitoring for apnea for all preterm infants who are still under 60 weeks of post-conceptual age, and also for full-term infants who are under 4 weeks of age for 12 hours post-anesthesia, which basically excludes all ASCs. They also recommend that full-term infants who are over 4 weeks but under 6 months of age undergo 2 hours of monitoring before they are released to go home. And the recommendation is that they are scheduled early in the day to allow for that 2 hours of observation. And although not in the policy statements, they recommend avoiding narcotics and using regional or local anesthesia to control for pain in these patients. How about preoperative fear and anxiety in ambulatory patients? These are real, and one of the reasons for fear is the fear of separation from the parents. And there are 2 ways to address this. One is to sedate the patients, and that usually is done with PO midazolam, usually 0.5 milligrams per kilogram. And if given at the proper timing, which is about 15-20 minutes, it's effective. However, it can result in prolonged immersions and sometimes increase in postoperative vomiting. The other issue, or the other approach rather, would be to avoid separation altogether, allow the parents to participate in the induction, either in the operating theater itself, if they can be attired appropriately, or if you are lucky enough to have specific induction rooms, the parents can be there, as you can see in this picture here, without having to be dressed in OR attire. And there is a recent paper, just came last month, showing that using an induction room with the parents present is quite effective in reducing anxiety in these children. The other reason for anxiety is the issue of needing to starve the children. Preoperative fasting is a balance between safety and comfort. We want the children to be happy, but we do not want to compromise safety there. And the current guidelines now allow for 1 hour of fasting for clear liquids in almost all healthy children undergoing elective surgery. Is this safe? There's a study that looked at 10,000 children who were given clear liquids until sent for to the theater, which is about an hour, hour and a half. And out of the 10,000, there were 3 aspirations, and they all recovered without instance. So the safety is there. Are there any benefits? Yes. Kids are not thirsty, they are happier, the parents are happy, there is less hypovolemia, less hypotension, and less hypoglycemia if there is sugar in the drink that they consume. Parents always ask, what is the clear liquid? And the answer is sometimes confusing, but the simple answer is something that you can see through. You can read the newspaper through it, like water, sugar water, coconut water, apple juice, or ice chips. And most recommendations do not have volume limits. The children can drink as much as they wish. What is not a clear liquid is anything with pulp, like orange juice with pulp or Jello. And in spite of these relaxed guidelines, parents not always comply with the reduced fasting requirements. We have looked at this a few years ago and found that that is especially true in children undergoing early surgery, because the parents are more reluctant early in the morning to wake up the children to give them something to drink. And these are the number of children who had more than 8 hours of starvation before coming to early surgery. Nice approach, which just got published about a month ago, is to make sure the parents are reminded in the morning via text. Almost everyone now has a smartphone. And they found that if you text the parents in the morning, telling them to give the child fluids before coming to the facility, you can see on the right side that the starvation period is about 2 hours, whereas those who were not receiving a text has a starvation of about 7 or 8 hours. So that's an easy, inexpensive way to ensure compliance. Must children drink before discharge from day surgery? Schreiner looked at this a few years ago and found that children who were forced to drink, shown here in blue, had more vomiting and resulted in longer stay in the facility than those who only drank when they wanted to. Should kids be required to void before discharge from day surgery? And the answer is no, even after a caudal block, because kids, especially little boys, don't have the prostate problems that older men sometimes have, and voiding, unless you are really concerned about the state of hydration, is not a criterion for discharge from day surgery. Another debate that is still current is whether IV access is required for all patients undergoing elective surgery at an ASC or as ambulatory patients. And the issue is that IV access in little babies is not always easy. And it's not always necessary. I mean, there are patients where established IV access may take longer than the procedure itself. And if the solo practitioner is doing the case and having to start an IV, complete attention to the airway may be compromised. There is precedent for that because for some surgeries like ear tubes or EUA, IV is not usually even attempted. Give you an example of a child that I used to see frequently in my practice. A 6-month-old toddler who is otherwise healthy undergoes an easy sevoflurane induction, and then I try and some other assistants try, cannot get an IV. What are the options? I can either secure the airway with an LMA and proceed, or wake up the child and cancel the case, which is very inconvenient and undesirable. Is it safe to secure the airway with an LMA before an IV is inserted? And there's a study here showing that LMA can be placed safely in children prior to IV placement or without IV placement, as long as a child is deep enough not to react to the insertion of the LMA and manipulation of the airway. And this can be determined by either looking at the heart rate. When the heart rate starts to slow down, the child is probably deep enough, or by looking at the mandibular relaxation. If you can open the mouth and relax the mandible, you can safely insert an LMA. This is more likely to be practiced by more experienced anesthetists. A study from the UK shows that willing to do anesthesia without an IV in place is more prevalent among consultants who have more experience. Almost half of them, 45%, were quite happy to do that, whereas with less experienced trainees, less than 1 in 5 was comfortable enough to proceed if an IV could not be inserted. Moving over to tonsillectomy, which is the second most common procedure that we see in children at an ambulatory surgery center, only second to ear tube insertion in our practice. We see over 500,000 cases a year in the US of tonsillectomy. Some are for chronic tonsillitis, but these days, most of them are for sleep disordered breathing, which is now becoming the primary indication for surgery in almost 9 out of 10 children. The issue here is that sleep disordered breathing is a spectrum of findings. Not all the children are the same. Some will come for simply snoring loudly, as shown here on the left, and some will come because they have obstructive sleep apnea syndrome. And in these cases, you have chronic intermittent hypoxemia at night, you have upregulation of the mu receptors in the midbrain, and that results in increased sensitivity to opioids, which has unfortunately resulted in many children actually dying when receiving opioids postoperatively if they have had severe obstructive sleep apnea and was discharged home. The selection criteria for T&A at a freestanding ASC in our facility is age over 3, which is a national recommendation, no severe OSA, as opposed to simply having loud snoring. And unfortunately, most of the time, this is determined by history, because most children, 9 out of 10, will come to have tonsillectomy done without having sleep studies to confirm the degree of airway compromise. They should have no comorbidities, genetic syndromes like Down syndrome or neuromuscular dysfunction, and this includes also not being severely obese. The current American Academy of Otolaryngology Head and Neck Surgery guidelines suggest that these children should have aggressive perioperative hydration, should have adequate analgesia with opioid-sparing approach. And I need to emphasize here that opioid sparing does not mean no opioids. It means basically using a combination of low-dose opioids plus other adjuvants like paracetamol or dexamethasone sometimes. Antiemetic prophylaxis is important, usually with ondansetron 0.1 milligram per kilogram, using dexamethasone, usually 0.5 milligram per kilogram, to prevent swelling and also help control postoperative vomiting. And they emphasize that there is really no place for antibiotics during routine tonsillectomy surgery in children. Now, when I say opioid sparing, one needs to know how sensitive the children are to opioids. And one way to do that is to do a fentanyl test dose, as had been described by Wu from China. And what he did was to give a dose of fentanyl, 1 microgram per kilogram, following induction, but before endotracheal intubation. And during 5 minutes, would watch to see what happens to the respiratory rate. And on the left side of the screen, you can see patients who had severe OSA will have a very significant drop in respiratory rate in response to that dose of fentanyl, whereas those who had no OSA or not severe OSA had only very moderate drop in respiratory rates. So that's a good test that tells you how sensitive these children are to opioids. I don't really like to wait 5 minutes before I intubate my children, and I like to do my test dosing during surgery after the patient has been intubated. And I use a smaller dose of fentanyl. I use 0.5 microgram per kilogram and watch for the respiratory rates and the end-tidal CO2. And this patient here, who is quite sensitive to opioid, basically became apneic from this very small dose of fentanyl. And when he came back breathing again, his CO2 was in the 70s. So I know that this child will not receive any more fentanyl during surgery or any other opioid or other, and will not have post-operative opioid prescribed because he has proven to be very sensitive to opioids. One of the options to avoid opioids is to use dexamethasone. And dexamethasone, especially in this study here, giving a dose of 2 or even 4 microgram per kilogram, can actually eliminate the need for opioids in the first hour or so of recovery, but at the expense of prolonging emergence and PACU stay. So it's not a drug to be used in a freestanding ASC. It's only appropriate in an hospital-based environment where prolonged stay or even need for admission can happen there. What many of my colleagues do is to give a smaller dose of dexamethasone, like 0.5 microgram per kilogram, which will help reduce the need of other opioids, and again, minimally delay emergence. But that is only done in the hospital-based facility and not at the ASC. The airway management for T&A is usually with endotracheal intubation. 88% of the patients are intubated. Flexible LMA, which in this current review here was used only for 12% of the patients, mostly for adenoidectomy. And the advantage of LMA, flexible LMA, is that it's quicker to insert, quicker to remove. However, it does obstruct the field for tonsillectomy surgery, and very frequently it needs to be readjusted during the procedure. So it does not, in the long run, does not really save time for surgery. When patients are intubated, most of the time, 4 out of 5 are extubated awake in the operating room, and 1 out of 5 is extubated deep in the operating room. Now, we must remember that T&A is an aerosol generating procedure. And even in patients with negative PCR tests for COVID, the risk of transmission to the faculty and staff is not zero. In our facility, full PPE, full protective equipment is mandatory, even though it's cumbersome, impairs vision, and impairs cognition, and may even slow down the anesthesiologist and surgeon's performance. Why safety comes first, and it is a requirement for all these patients in our facility, and we actually do a COVID timeout in these cases so that we make sure that everyone is properly attired before we continue with surgery. The risk of bleeding after T&A at a freestanding ASC is very small. In our facility, we had 2 out of almost 1,000 patients who required reoperation. There was no mortality, and we still find that you have to prepare the parents, tell them that if there is any chance of bleeding, to go to the nearest hospital and call the facility for further instructions. How long do you keep the patients in a freestanding ASC after tonsillectomy? Most of the time, it's around 2 hours, 1.5 to 2.5 hours. Some facilities can keep them longer, 3 or 4 hours, but that usually is in a hospital-based facility, not in a freestanding ASC. And finally, looking at obese patients in non-airway surgery. Obesity now is very prevalent. Not only the parents, the children, or even the pets are overweight now. And our guidelines at our ASC, freestanding ASC, is to look at young children looking at the BMI percentile for age. And we choose a 98% percentile for age as our cutoff limit. In some places, 95%, and others, it's 99%. For adolescents, we look at pure BMI value, and we look at under 30 as our accepted limit there, as long as they have no comorbidities and no obstructive sleep apnea symptoms. We allow for exceptions by consultation. So why do we have guidelines and still allow for exceptions? Because BMI is not really an indicator of obesity. Many of the adolescents who are very athletic, who have a lot of muscles built up, will have high BMI value because of the muscle weight, not because they have a lot of fat there. What are we worried about? We're worried about complications during surgery. Patients who are obese, shown here in red, have more chance of having difficult mask airway and difficult laryngoscopy. And because of that, even if we accept some of these obese children for ambulatory surgery, like in this case here, having ear tubes, we do that in the hospital-based facility and not in a freestanding facility. I have very low threshold for going ahead and dropping an LMA in this case here, even for a brief period. Surgery for ear tubes is not very long, but having a secure airway is very important, and avoiding the head movement will help the surgeon finish the procedure much more quickly. More importantly, the complications in obese children following surgery are upper airway obstruction, which is much more common, again shown here in red, in obese children, longer stay, more than 3 hours, and twice the chance of unplanned admission. So to sum up, this is a brief overview, and we used examples of young and obese patients and managing T&A procedures to show that ASCs, freestanding ASCs, are best reserved for healthy children undergoing low-risk surgery, while more complex patients can still undergo ambulatory anesthesia and surgery in a hospital-based environment where a longer stay and overnight monitoring can be arranged. Thank you for listening, and thank you for keeping our children safe.
Okay, thank you for your nice and informative presentation. Okay, Teddy, please.
Yeah, thank you very much, Professor Rafat. Very interesting talk, and I'm sure there's a lot of questions, comments, or clarifications from our viewers. Please key it in and share it in our Q&A box below. Moving forward, our next speaker is Professor Young Eun Jung. I will be speaking on post-operative care, including pain management after ambulatory surgery. He is a clinical assistant professor from Seoul National University Hospital, College of Medicine, and he's very active in various anesthesia society in Republic of Korea. He has special interest in ultrasound-guided vascular access, regional anesthesia, NORA, pediatric procedural sedation, and ambulatory anesthesia. So colleagues, please welcome Professor Young Eun Jung. Thank you.
University Hospital. It is a great honor for me to giving the lecture today, and I want to thank ASPA for the kind invitation. The topic of my presentation is postoperative care, including pain management after pediatric ambulatory surgery. I have no conflict of interest. These are the contents of my presentation. First, we'll look at the goal of postoperative care and common problems after pediatric ambulatory surgery. Then we'll move on to the specific issues, pain and POMV management after pediatric ambulatory surgery. The first pediatric ambulatory surgery has been performed more than 100 years ago. The development of short-acting anesthetics has led to the increase of ambulatory surgery. Recently, more than 60% of surgeries performed in the ambulatory setting in the USA. These are the goals of ambulatory surgery. When you focus on the postoperative care of ambulatory surgery, the goal is to reduce inpatient admission, to encourage early recovery, early mobilization, and early return to daily life. Several conditions must be satisfied for safe discharge: consciousness and activity, respiratory stability, oxygen saturation, hemodynamic stability, pain, POMV, and surgical site condition must be evaluated before discharge. Now we'll move on to the common problems after pediatric ambulatory surgery. As a pediatric anesthesiologist, unanticipated admission would be the last option for your ambulatory surgery patient. According to the large-scale retrospective study of pediatric ambulatory surgery, the incidence of unanticipated admission is low as 0.97%, but significant. Anesthesia-related causes accounted for the majority of admissions, followed by surgical, medical, and social causes. Respiratory causes including hypoxia, apnea, airway complication and aspiration, pain, and POMV were the most common reasons for unanticipated admissions. Predictive factors of unanticipated admission include age under 2 years, ASA class 3, type and duration of surgery, as well as the presence of intraoperative event or obstructive sleep apnea. Let's look at the respiratory complications briefly. Patients with obstructive sleep apnea have a high risk of postoperative hypoxia after ENT surgery and should be managed with caution. These patients also have a high risk of laryngospasm, which causes hypoxia and prolonged recovery. Additionally, I want to emphasize the risk of residual neuromuscular block. According to a recent study, the incidence of residual neuromuscular block was about 27% after the pharmacological reversal of pediatric patients at PACU. As residual neuromuscular block is an important clinical problem and is correlated with morbidity and mortality in the postoperative period, quantitative monitoring of the depth of neuromuscular block should be implemented for safe anesthesia in all pediatric patients. In summary, careful anesthetic management in high-risk patients such as OSA, avoiding intraoperative airway-related events, and full recovery from the neuromuscular block is the key point of preventing respiratory complications. Now we'll move on to the postoperative pain after pediatric ambulatory surgery. Children do need postoperative pain management. A recent study asked children aged 4 years or older to assess the postoperative pain and its impact. Interestingly, around 20% of children expressed the desire for more pain management after tonsillectomy. This was associated with higher pain scores, pain interferences, and more side effects. In children who did not need more treatment, preventive administration of at least 2 kinds of non-opioid analgesics before emergence was found. This modifier factor should be used to improve postoperative pain outcomes and decrease the opioid-related side effects after pediatric ambulatory surgery. There is a well-structured guideline for postoperative pain management in children, European Society for Pediatric Anesthesiology 2018 guideline. It offers postoperative pain management protocols for 6 common pediatric surgical procedures with 3 levels of pain management ladder. Pain management ladder for inguinal hernia repair, circumcision, and adenotonsillectomy can be used for ambulatory settings. The guideline emphasizes protocol-based pain management and suggests attaining at least the basic level of the ESPA pain management ladder. The basic level uses drugs and methods that are widely available, are proven to work, are safe, and do not require any complex monitoring. The intermediate and advanced levels are complex pain management suggestions which need resources and well-experienced physicians. Intraoperative ultrasound-guided regional anesthesia is the key point of intermediate and advanced pain management level. The guideline also offers comprehensive dosage suggestions of non-opioids, opioids, and local anesthetics for pediatric patients. Now I'm going to talk about opioid-free anesthesia in pediatric ambulatory surgery. As you know, the opioid crisis or opioid endemic is a very serious problem these days. Persistent opioid use was found in 4.8% of pediatric patients after surgery, compared with 0.1% of those in the non-surgical group. About 3 to 5% of pediatric patients show persistent opioid use even after pediatric ambulatory surgery, such as adenotonsillectomy, umbilical, epigastric, inguinal hernia repair, hypospadias repair, or oculopexy. Therefore, efforts have been made to reduce the use of opioids, especially in pediatric patients. This recent study is a good example of quality improvement efforts for an opioid-free pediatric ambulatory center. The authors reviewed the ambulatory anesthesia and pain management protocols in 2017 and replaced the fentanyl, morphine, and acetaminophen with dexmedetomidine, NSAIDs, and regional blood during 18 months project. This slide shows the protocol change in ENT, urology, and general surgery. And this slide shows the protocol change in orthopedics, dermatology, and ophthalmology. During the quality improvement project, it reduced the intraoperative opioid administration from 84% to 8%, and postoperative morphine administration from 11% to 6% using a combination of dexmedetomidine, NSAIDs, and regional blood. It also decreased the POMV without change in the maximum pain score, duration of anesthesia, or PACU stay. Dexmedetomidine is a useful option in pediatric ambulatory surgery. It offers intraoperative anesthesia and decreases emergency agitation without delaying the PACU stay. The recommended dose of dexmedetomidine is shown in this slide. To prevent emergency agitation, a loading dose of 0.3 to 0.5 microgram per kilogram is recommended. And for opioid sparing, 0.5 to 1 microgram per kilogram is recommended. The continuous infusion is optional and may be used for surgery that takes more than 1 hour. As dexmedetomidine can cause bradycardia and hypotension, preemptive use of atropine sulfate is useful in pediatric patients. If the patient needs prolonged pain control, there is a report that uses the continuous regional anesthesia after from late surgery and children and adolescents. In summary, opioid sparing during anesthesia and postoperative pain management is an important issue in pediatric ambulatory surgery. Use of pain management protocols, preemptive use of non-opioids such as dexmedetomidine and NSAIDs, and utilization of regional block is the key point of postoperative pain management. Now we'll move on to the POMV after pediatric ambulatory surgery. The pediatric population is at high risk of POMV. The well-known risk factor of POMV in children are the duration of surgery, 30 minutes or more, age, 3 years or more, strabismus surgery, and history of POV or POMV. In 2020, there was an update in the consensus guideline for POMV management from the Society for Ambulatory Anesthesiology. The family history of POV or POMV, post-pubertal female, Adenotonsillectomy, autoplasty, volatile anesthetics, anticholinesterases, and postoperative long-acting opioids were introduced as new risk factors of pediatric POMV. According to the number of risk factors, the prophylactic regimen changes. The key elements of prevention are dexamethasone, serotonin 5-HT3 antagonist, and the use of total intravenous anesthesia with propofol. For rescue treatment, different classes of antiemetics are recommended. Non-pharmacologic interventions are also effective strategies for reducing POMV, minimizing fasting time, preoperative carbohydrate loading, and intravenous hydration to maintain clinical euvolemia. This guideline gives useful information on the antiemetic dose for prophylaxis of POV in children. Additionally, a recent study investigated the effect of thirst on the POMV and opioid use in pediatric ambulatory surgery. They also thought that the postoperative distress can be caused by pain, emergency delirium, or thirst. When the apheresis was 4 or more, they gave diluted apple juice instead of opioid protocol for pain. This intervention decreased the incidence of POV from 24% to 11%, and also decreased the use of opioids and PHU time. So far, we've looked at the POMV management in pediatric ambulatory surgery. Risk assessment and prophylactic guideline for POMV should be used in pediatric ambulatory surgery. Reducing fasting time, preoperative carbohydrate loading, and early postoperative hydration can reduce the POMV. In this lecture, we've looked at the recent updates of postoperative care after pediatric ambulatory surgery. Changes are needed in daily practice, and I think that we, pediatric anesthesiologists, should lead the change in clinical practice for our patients. Be careful with high-risk patients and avoid the anesthesia-related events to reduce unanticipated admissions. Pain management protocol after pediatric ambulatory surgery should include opioid-sparing, non-opioid analgesics, and ultrasound-guided regional blood. Key points of POMV management are risk assessment, pharmacologic, and non-pharmacologic prevention. This is the last slide, and these are pictures of the new Pediatric Ambulatory Center in Seoul National University Children's Hospital. Thank you.
Thank you very much, Professor Young-eun, for your very interesting talk and for highlighting the International Pain Society's advocacy for opioid-free ambulatory surgery. So moving forward to our next speaker, she'll be discussing anesthesia for ambulatory surgery in children with special needs. She's a professor and head of Department of Anesthesia, Faculty of Medicine, University Malaya, Kuala Lumpur, Malaysia. And she is the upcoming president for both Malaysian Society of Anesthesiologists and Malaysian Society of Pediatric Anesthesia. Her special interest includes pediatric anesthesia, difficult and advanced airway management, and medical education. Ladies and gentlemen, please welcome Dr. Ina Ismiarti Sharifuddin.
Hello, greetings from Malaysia. Hi, I'm Ina. Today, I will share my thoughts with you on anesthesia for ambulatory surgery in children with special needs. Thank you, ASPA, for this kind invitation. For the next 20 minutes or so, this is my outline. Who are the children with special needs? What are the concerns of anesthesia in this group of patients, the preoperative management, and some take-home message. For the purpose of this talk, the term of children with special needs encompasses the children with learning disability, with IQ less than 70, children with language and communication disorder, children with any disability that prevents a child from coping well with new experiences. The children with learning disability is more prevalent in Asian community. There is a slight male preponderance to this. They can exist with just learning disability, but with robust physical health, such as children with autism, or children with a learning disability that is associated with congenital abnormalities such as Down syndrome and cerebral palsy. These children benefit the most from daycare surgery. This is because with daycare surgery, they can go back to their normal routine and environment and recover there accordingly. So when do we see them? We see them in dental procedure when they come in for dental caries, for ENT procedure when they come in for EUA or insertion of bone mat, MRI to do MRI brain, or even for upper GI scopes and eye surgery. What are the concerns with anesthesia? Mainly the concerns is due to their coexisting medical problems in them. They're at a higher risk of developing epilepsy. The frequency is up to 44%. And they also are at a higher risk of getting psychiatric conditions. And the frequency can go as high as 50%. To note, they also are at risk of getting gastroesophageal reflux, and the incidence is about 49%. The children with learning disability and is associated with congenital abnormalities are also predisposed to difficult airway. Hence, as anesthetists, we should look hard for any features of difficult airway in this patient. So who can be treated in day surgery setting? The child should be, first of all, well with only mild or well-controlled comorbids. And these children with relatively complex needs can be done in day surgery, provided they are stable with minimal cardiorespiratory problems and they do not have features of difficult airway. The challenges that we face in them varies. One of the most important one is polypharmacy. These children, as you know, are on stimulants and antipsychotics, such as Ritalin or olanzapine. And as such, these drugs can predispose this patient to have hypotension after exaggerated hypotension of the induction of anesthesia. Psychosocially, these children are very, very anxious. So they may have difficulty in conforming to the usual pattern of hospital care. Hence, most of the time, hospital attendance is often stressful to the whole family. The aim in perioperative goal is to provide quiet environment for them to wait and to come for anesthesia. We must maintain communication with parents and child when possible. And when we are going to do an induction of anesthesia, it should be a smooth induction. And we should provide intraoperative PONV prophylaxis for them. We should also ensure adequate analgesia and adequate hydration. And at the end, we should provide additional sedation for smooth post-operative recovery when deemed necessary. We can use medication known to decrease the incidence of emergency delirium if we expected or suspected that they would be having one. Last but not least, cure the intravenous lifestyle when sending them to recovery. For this, at pre-admission, we should adopt a flexible and holistic approach to care. We as anesthetists should coordinate intervention required by multiple subspecialties in one setting, i.e. in one anesthesia. And the staff, all the healthcare workers should consider families and patient needs when managing this patient perioperatively to prevent any or avoid any preoperative admission anxiety. We can collect all information needed to look after them over the phone prior to coming. And this paper done by Tegizade et al. On the experiences of children with autism spectrum disorder, their caregivers and healthcare providers during their procedure, they concluded that there is a problem with communication between healthcare worker and family. Family expect that there should be good communication with them. They expect that there should be clear plans and explanation what that is expected for them and their children while receiving treatment. They also expect that staff should show a little bit more empathy when discussing this management plan with them, as the whole family is often in a stressful time at this period. They also recommend that hospitals should have individualized care within the hospital framework itself. Healthcare workers should work with a flexible protocols around them. We should avoid unnecessary blood pressure measurement and not asking their children to change into hospital gowns when it is possible. These children is always anxious in unfamiliar environment, so it is our responsibility to reduce this anxiety. We could do this by having behavioral intervention or pharmacological intervention. We could do this by providing supportive aids, such as allowing them to come into operating theater with their favorite gadget, and or we can also ask them to play around with their handphone or tablet when inducing them. This is, of course, apart from having their parental parent next to them during induction. We could also get the assistance of play therapists to assist them when they are waiting in the reception area for their turn to come into operating theater. With this, their time will be occupied and they will be less anxious. As anesthetists, we could also learn to tell social stories to them. We can make them feel at home, a little bit more comfortable by telling them simple social stories on relating anesthesia and simple fairy tales around this procedure. On premedication, it was shown that when premedication was not given, non-compliance at induction of anesthesia is increased from 22 to 50%. Premedications modify behavior by providing amnesia, anxiolysis, and sedation. Drugs available are midazolam, dexmedetomidine, ketamine, and fentanyl. The route of administration can be oral, intranasal, and submucosal. Previously, we published a study on the dose of intranasal dexmedetomidine that is suitable for medication in children. We conclude in this study that children aged between 1 to 4 years old, intranasal dex in doses of 1 and 2 mg per kilo produce a similarly high rate of satisfactory sedation, whereas for older children aged between 5 to 8 years old, intranasal dex 2 mic per kilo was associated with a higher proportion of satisfactory sedation as compared to 1 mic per kilo, without causing any adverse hemodynamic effects. Other drugs that we can use for premedication are midazolam, ketamine, and fentanyl. Midazolam can be given as oral in a dose of 0.5 to 0.75 milligram per kilo, and the onset is within 10 minutes with a peak of 30 minutes. The maximum dose we can give is about 15 to 20 milligram. Intranasal route of administration is not recommended. That's midazolam is as shown as before, while ketamine, we can give them as oral at a dose of 5 to 6 milligram per kilo, and the onset is about 10 minutes. We, however, need to give antisalog like atropine 0.02 milligram per kilo to reduce salivation side effect of the ketamine. Fentanyl can also be given at a dose of 5 to 50 milligram per kilo orally. However, the setback of fentanyl is it gives PONV, and sometimes it can induce vomiting just at induction, and this can be hazardous to children. Just to note, the midazolam and dexmedetomidine is usually the first-line treatment for premedication in these children, and ketamine and fentanyl are normally left for the resistant patient to this to midazolam and dexmedetomidine, and they are normally the second-line drugs. When providing anesthesia, we should try to administer a simple and straightforward anesthesia. We should provide anesthesia drug that is determined by any coexisting morbidity. We should minimize postoperative nausea and vomiting by administering anti-emetic agent and provide adequate hydration with isotonic crystalloid fluid ulysis. For analgesia, simple analgesics should be used routinely. We should prescribe or administer IV paracetamol and ibuprofen where appropriate. Regional block is recommended where possible, and we should be more aware of sensitivity of certain syndrome with opioids, such as Down syndrome. And in this patient, we should use a reduced dose. In emergency delirium, it has been shown that emergency deliriums have a correlation with preoperative anxiety. The odds of experiencing emergency delirium might increase with the increase in preoperative anxiety. And we know that children with learning disability may be super anxious when they are with us. So this can be treated with drugs. Let's have a poll. Which drug is shown to best reduce ED? Is it IV dexmedetomidine, IV fentanyl, IV ketamine, or IV propofol? It's interesting to see the choice of our audiences. So yeah, 69% of our audience choose to give IV dexmedetomidine and 25% choose to give IV propofol. So let's see what does the literature recommends. Before that, I recommend that all of you close the poll. In this paper by Nair et al., published in BGA Education, it is shown that a drug that can be used to prevent ED are propofol, midazolam, clonidine, dexmedetomidine, fentanyl, even gabapentin, magnesium infusion, dexamethasone, and ketamine. However, in this same paper, they stated that intravenous 0.3 mic per kilogram of miditomidine at the end of surgery reduces the incidence of emergency delirium from 47 to 5%, and it has been shown to be superior to propofol bolus of 1 milligram per kilo at the end of the surgery. These patients, when they come to recovery and when they wake up, they may become agitated due to anxiety, pain, or nausea, which may be hard to diagnose. The caregiver should be brought to the child early to allay any fears and assist with communication. We should ensure all fluid and drug administration be completed promptly in recovery. This is to allow early removal of the IV cannula, which most of the time cause a lot of problems to this stage. Be discharging them to their normal home environment as soon as their condition permits. In assessing pain, it could be difficult to assess this patient as they may have difficulty in expressing the location and the intensity of pain. Hence, we need an appropriate tool to assess them. We should use validated observational skills such as FLEG or the non-communicating children pain checklist to assess pain in them. The FLEG consists of a few categories, that, which is the face, legs, activity, cry, and consolability. And we should score them accordingly to how we observe them when we're assessing them. In providing care for this patient, it has been identified that from the study done by our colleague in Melbourne that there is lack of staff awareness when dealing with children with special needs. This is due to the inadequate training of staff about children with learning disability. They also identify that lack of suitable equipment and environment causes these children to have prolonged waiting times for operation date, prolonged waiting on the day of operation, and lack of private space and lack of non-invasive equipment. We should highlight all this problem to our hospital management so that we can offer a more suitable and friendly environment for this patient, as now we are seeing more and more children with special needs in our daycare setting. This is my last slide. Just to conclude, I'd like to emphasize that careful selection of patient is very important as day surgery benefits these children. Children with special needs require a multidisciplinary approach to ensure optimal care. Awareness and understanding of their special requirement is essential when devising a management plan for them. Identifying barriers to care can help guide improvement in the care of these children. So with that, I'd like to thank you. If you have any question, you can send email to me. Thank you.
Okay. Okay. Thank you all the speakers for the excellent presentation. This is the Q&A time, and Dr. Teddy Fadla will moderate this session. Dr. Teddy, please.
Hello, hi, good afternoon. So thank you very much. Biba, can we proceed to gallery view? Thank you. All right, so we have a very lively Q&A section box, and I think Dr. Ekta actively answering quite a number of questions in the Q&A chat box. But my first question for Dr. Ekta is regarding, you mentioned earlier on regarding the codes when you are canceling or accepting a patient for a patient with URTI and you have a code scoring. In this time of pandemic, any adjustment with that code scoring that you use in your institution when it comes to accepting or deferring patient for surgery if they have URTI symptoms?
So we are still following the same. Can you hear me, Teddy?
Yes, clearly. Thank you.
Yeah. So for all surgeries, anyway, preoperatively, we are doing COVID testing. And as Dr. Rafat said that for T&As, or for shared oral airway surgeries, we are a little careful about the PPE what we wear, and we completely wear the complete PPE. But once COVID negative is there, the cold scoring stays the same. We are not modifying it any further.
I see. So noted on that, Dr. Ekta. So one question for Professor Rafa. Thank you very much for that very informative presentation earlier on. And one question is that GA without IV, is it legally acceptable at this point? Because there are some who actually highlighted that they are not comfortable without IV if they are just carrying on with the just gas, holding the mask for patient for short procedure. What's your thoughts on that, Professor Rafa?
There are no definite guidelines. I think it depends on the comfort level of the anesthesiologist. And as I have indicated in the UK study, with experience, people become much more relaxed in doing so. Again, there are some procedures we don't normally start IVs for ear tube insertion or for examination under anesthesia. And there is a risk that if you divide your attention between managing the airway and trying to start an IV if there is no assistance, that can be even worse than proceeding without an IV. There's no right or wrong answer. There are things that I would not do without an IV. For example, a hernia procedure, I will not put a caudal block if I don't have an IV in place. And one should always have a backup plan. For example, you should always have an IO intraosseous backup available in case of an emergency. So there's no good answer. I think it depends on the level of comfort of the anesthesia provider.
Yeah. So in the end of the day, it's a matter of experience and how well prepared you are for plan B, C, and D in events of crisis inside the operating theater. But of course, it all depends on our experience. Okay, moving to Professor Zhang. I think you managed to answer the question regarding neuromuscular blocker antagonists like Sogamadex. Would you like to just briefly give us your points on that? The question is that should neuromuscular blocker antagonists like Sogamadex administered to all outpatient pediatric cases, most probably if you use rocuronium, I guess. What is your opinion on that? Yeah.
Thank you for your question. I think that the use of neuromuscular blocking antagonist should be determined by the monitoring. When antagonists are needed, when the TOF ratio is less than 0.9, acetylcholinesterase inhibitor would be okay because Sugamadex is not cheap, and sometimes it causes allergic reaction. When the TOF ratio is more than 0.9, the use of antagonist is up to your institution or your opinion. I personally prefer administrating neuromuscular blocking antagonists. And as the acetylcholinesterase inhibitor needs time to act, usually 2 or 3 minutes, so we have to be careful with airway management before full reversal of neuromuscular block. Thank you.
All right, I'll stay on Professor Zhang. I think the following, there's a lot of questions regarding pain reliever, and you are one of our pain experts in our panelists. So there are questions regarding NSAIDs like Brufen, Parecoxib, and Tramadol, and IV paracetamol. And mainly the question is like the age group. That when is it safe to give, particularly for Brufen, and I think there's one question regarding IV Parecoxib or IV Ketorolac as well. Yeah.
So as the pediatric patient needs, many of the drugs are not studied in pediatric population for safety and efficacy. So in our country, the use of acetaminophen, IV acetaminophen is not allowed under 12, and the tramadol is not allowed for pediatric patients. So we use off-label IV medications for postoperative pain management. So we usually use IV acetaminophen, and when the patient needs more pain control, we usually use ketorolac first and then use opioids later. Does it answer the question?
Yeah. I think for KK, for us, we use Brufen. Usually the FDA recommendation, you should use it for 1 year old and above. But there are some cases wherein you can go as young as 6 months and above. Yeah, then you can use celecoxib for 2 years old and above. Yeah. And I think there's another question for this one. Maybe I'll ask Professor Rafat regarding tonsillectomy and NSAIDs. So in your, you mentioned earlier on about the medication and pain reliever as well for tonsillectomy. What's your opinion regarding usage of NSAIDs like ibuprofen for tonsillectomy? Maybe they're highlighting about possibility of post-tonsillectomy bleed. Yeah.
I think the current guidelines of the American Academy of Otolaryngology is that it is safe to use NSAIDs, especially if you wait until the clot is formed. So I would not recommend giving ibuprofen, for example, during or before the surgery is finished. But when the patient is already in recovery and there is no bleeding, it's perfectly fine to give ibuprofen. And it has been shown that it's very safe. The only time when we had severe bleeding reported was in patients who are already on aspirin, let's say for cardiac prophylaxis. And then they receive NSAID ibuprofen after that. There is no higher incidence of bleeding, but when bleeding occurs, it's more severe, that requires reoperation much more frequently.
All right. Okay. Going to Prof. Ina. There's a question here regarding how would you address the distress faced by patients with special needs if they had received LA or any regional technique after the surgery? I think most of the time that this particular patient, they are not in pain when they wake up. They're most probably like they are stressed because of the numbness, because it's a new sensation for them, right? Particularly for dental surgery. So how do you actually address this, and what are the preemptive measures that you would suggest to our viewers?
Hi. That is a very tricky question and a tricky situation to be in, because even in a normal child, having this numbness after dental surgery with LA is very, very difficult. It can be difficult to calm them down. What more with children with learning disability. So I think, as I have said in my lecture, the journey starts from the beginning, where at your pre-op or pre-op planning, you have to really tell the parents and the child, although normally they might be having learning disability, but at some point they can understand if they're big enough to what the process they're going to go through. So we have to really, really explain to the parents that apart from the pain, what else could happen. And intraoperatively, if you think that this patient will wake up and going to trash because of the problem with not understanding what's going on, then I would preemptively give drugs to prevent this from happening. I would start some IV Dex at the end and let them wake up slowly. And when they wake up at the recovery slowly, normally this feeling will be a bit more easier to tackle. And by the time we get the mom or the parents or the caregiver in there, they would be able to comfort this child accordingly. However, this is easier said than done. Having done that, I've seen that these children could be very, very distressed.
Yeah, I'm sure. Going just to briefly ask, we mentioned about Presidex earlier on, even to your discussion that wherein you give IV 0.3 microgram per kg of Presidex, right? And it's more superior than Propofol. There's a question here whether how do you actually administer the 0.3 mics per kg? Do you give it bolus, or do you actually dilute it and give it over 10 minutes or 15 minutes? Any suggestions to our viewers?
The study that shows this, I did it with diluted, and they give it over a short bolus, 10 minutes. So this is not something that you give when they are at recovery and they're jumping around, you know. So this is something that you would give when you anticipate it. So you give it at the end of the surgery, diluted, give in a 10 minutes slow bolus. Because of the effect of dextromethorphan, if you give it too early, can very fast can cause problem.
Yeah, I think Professor Rafa had also highlighted that earlier on, that if you give it too late, if you give it a high dose bolus, you can have a delay in emergence regarding surgery. Okay, last question before we end. I think that I've seen 2 questions regarding ketamine. At this age of polypharmacy, multimodal opioid sparing approach, is there any role for ketamine? I think I'll ask everyone. Let's start with Prof. Ekta. What's your point regarding ketamine? Is there the role of ketamine for ambulatory surgery at this point of age?
So low doses like for analgesia, something like 0.25 to 0.5 milligram per kg, it's okay. But then depends on why you are trying to use it. There are plenty of drugs. You have dexmedetomidine, you have good drugs around. But yes, if you don't have other drugs, ketamine in correct doses can be an option.
Yeah, Prof. Rafat, in your practice, do you still use ketamine as one of your opioid sparing?
We use ketamine, sometimes PO, in combination with midazolam for very big autistic children who are refusing any other way of induction, but usually in the hospital-based facility, not at the ASC.
Any dose that you will recommend if you're giving it as oral?
If we give it PO, we give 5 milligrams per kilogram with midazolam, 2 milligrams per kilogram. We also can give it IM. If you have somebody who refuses to take PO, you can give 2 milligrams or 3 milligrams per kilogram IM, and then run away quickly until the child calms down.
All right, Prof. Yang-En, in your practice in Korea?
So ketamine is not the first option, but it can be used for some specific issues. So nowadays we are trying to use the dexmedetomidine and ketamine for to sedate children. So we are planning some studies using these 2 drugs combination in for intranasal administration when the child has no IV access. So as bradycardia can be caused by dexmedetomidine and ketamine causes tachycardia, some good combination can be used for special children's, I think.
If you give it as a combination, do you give it as a pre-med or you give it as an intra-op medication as well?
We are planning to give it as a pre-medication or for procedural sedation.
I see. Prof. Ina, last one for special needs, children with special needs. Which do you still use ketamine, or you are happy with just propofol or Precedex?
I think with just this is for pre-medication, right, Teddy?
Pre-medication or intra-op or emergence delirium?
For pre-medication, normally the ketamine, I use it as like what Prof. Rafa said, as a second line when they are resistant to midazolam, and also if they are coming like on regular basis for certain procedure, we would know that these patients are resistant to the previous sedation or not. And this is in this sort of patient, I would use ketamine for pre-medication. Yeah, so otherwise I'm not a big fan of ketamine for pain relief, because I think the procedure that we do in daycare don't really need much pain medication. You know, they should be something that we can treat with simple drugs like paracetamol, brufen, and simple regional analgesia, regional anesthesia for them, regional block for them. Yeah. So
I think long and short of it, for ambulatory surgery, we prefer to have an on and off drug, something that can easily digest and easily recover from it. Yeah. All right. Thank you very much to all our panelists and speakers. A very lively talk to everyone. I hope we managed to answer majority of the questions from our viewers. But before we end, we would like to announce a few things. So for your certificate of attendance tomorrow, you will not going to receive it today, but you will receive it tomorrow for our post-webinar survey. It will be forwarded to your email at about 5 p.m. tomorrow. Please make sure that you will key in your correct name and email, because we have a lot of problems with we cannot send the certificate because of wrong email entry. So please double check your email. So the World Federation of Anesthesia will be sponsoring the 17th World Congress of Anesthesiologists coming September 1 to 5, 2021 with the theme Connect, Learn, and Share. For all more details, please check their website at wca2021.org. Okay, our next webinar will be coming June 20, 2021. And this is the first part of 2 for our pediatric regional anesthesia. So please register. We will announce the registration in our website, in our Facebook page as well, and we will send everyone in their emails. For ASPA members, we will have our 14th ASPA Annual Virtual General Meeting coming July 18, 2021, 6:30 p.m. So please register. Registration will be sent through email, and save the date, everyone. Thank you. Then our next announcement, please save the date for our 2021 virtual conference. Singapore will be sponsoring this November 13 to 14. Our website is now live. You can check it at aspa2021.com. In relation to this conference, we will be having our ASPA pre-conference virtual airway workshop in the coming November 12. So the slots are limited, but we're giving priority to all ASPA members. So registration, we will announce. Please stay tuned in our Facebook page, our ASPA website, and of course, through your email as well. Prof. Hee-Soo?
Okay, thank you all the participants again for joining this webinar, and we appreciate the ASPA-FLEX webinar 11 team. Okay, see you next time. Good night.
Thank you.
Thank you.
Thank you.
Thank you.